Hello, everyone. Welcome to this training session. My name is Dana Awor. I work for African Population Health Research Center as a training program assistant, and I'd like to invite you all officially to this session. We're supposed to have 2 modules today, but unfortunately we'll just cover one. So we'll take Introduction to Mental Health Disorders and Research today. Then the second module, Mental Health Research, Technology and Data Gaps, will be covered in a later date that will be communicated to you. So a few tips, if at all you have any question, please feel free to put them at the Q&A chat. We shall cover them at the end of this training. And we'll also record this session and we'll share it at our platform together with any material that the facilitator would like to share with you. So without further ado, I'd like to invite the facilitator of the day, Dr. Frederick Wekesah. I'd like to give a brief intro about him. So Dr. Frederick Wekesah is an epidemiologist and a researcher. He holds a PhD in epidemiology from the University Medical Center of Utrecht in Netherlands. He also holds a Master of Science degree in medicine in population-based field epidemiology from the University of Wits in South Africa. Frederick is also a Bernard Loan Scholar in cardiovascular health program at the Harvard Chan School of Public Health in Harvard University. So without further ado, let me invite Frederick to take it over. Back to you, Frederick.
Many thanks, Diana. Please confirm that you can hear me.
Yes, we can hear you.
Great. And thank you so much for everyone who has made their time to join us today. Like some of you, I'm really excited that we're kicking this off. We will get into the details of that, perhaps a bit of recap on the structure of this program, because it's part of a bigger program, a bigger structure on the Mental Health Data Prize for Africa. And perhaps some of you are aware of the whole setup. Some of you are here for the first time. Perhaps would want to get a little bit more information on that. And therefore, I will just take a few minutes to, bring you up to speed on what this is meant to achieve, how the structure really has been put in place, and really what are the next steps and the processes that we hope to go through from now up to whenever this will be completed, and then what will happen thereafter. Diana, thank you so much for the kind introduction. And I really want to welcome the more than 280 individuals who have joined us today on this introduction topic. As you say, my colleague couldn't make it today, but we will reschedule that topic, the introduction topic on the data prize itself and the approach to the different data sciences approaches that we would want to take across in this program going forward. So I'll just share my slides just now in preparation for the presentation. Of course, that will take me a minute. Allow me, as always, the sharing button always disappears on a day like today. But I hope, Diana, you can again confirm that you can see my slides.
Yes, you can see your slide.
Thank you. Thank you so much. So again, I'll just take a minute to introduce us to the structure. This is a recap from the participant orientation that was done recently. There's quite a number of activities happening in the bigger scheme of the Mental Health Data Prize for Africa. To contextualize that, we call that Africa because there has been another one, but that was focused for Europe and the UK. But this is the first such prize that focuses on Africa, and that means the Africa continent and countries therein. So we will embark on a number of activities to actualize the vision to eventually award the prize to African researchers, African institutions, and a group of researchers, a multidisciplinary team that comes together to be able to showcase solutions for anxiety, depression, and psychosis, which are the conditions of interest for the data prize. But I'll explain a bit on why we arrive at those conditions and why they're important for us. So we at APHRC will be carrying out a scoping review for mental health data sets. These are akin to what has also been completed before by other colleagues elsewhere, and we'll be looking at what research has been conducted in the region, and that actually focuses on the three main conditions and in whatever study design that was employed in the region. And we're trying to do that in order to understand the landscape and get to really have a feel on what has been done, which gaps exist, which capacity also exists, and which kind of groups are working on what in which part of Africa. What we are embarking on today is part of one other session, which is the capacity building sessions. And I must clarify here that participating in these capacity building sessions, a number of the modules that have been selected based on a needs assessment is not a criterion for selection of the prize applicants. So we just hope that by participating in this, that you'll gain insights and knowledge and skills that can help you put together a proper bid for when the time comes to make the applications for the prize. But we have to state from the word go that what we are doing today, what we're embarking on today, is not a criterion for selection of the data prize applicants. We will facilitate matchmaking exercises based on interests and skill sets. And this really will be participant driven in the sense that when we receive requests from participants who would want to partner with other participants, perhaps in the same country or in the other countries, we will look at the profile of participants and try to bring common interests, common skill sets, or perhaps divergent skill sets together to be able to achieve, an objective for whatever proposal or project would be in the offing. So we will facilitate that. And on the projects, as you may have heard during the orientation, we will be keen at looking at a number of elements in the project that will be proposed. The proposal that will come to at the very end, we will hope that they will not be proposing to collect primary data, but they'll try to make use of data available data. So looking at data available within the institutions, within their programs, within their ongoing projects, and working on those data sets or whatever solutions they would be working on to provide innovation or solutions for anxiety, depression, and psychosis. Will also be that projects will look appealing if they apply longitudinal approaches. But again, we know that research is done in many different forms, many different designs, and that will not be a limiting factor. But really, as you can imagine, there are strengths in longitudinal data sets that would actually be very appealing when we'll be looking at those projects at the very end. When I say we are doing this together with the Wellcome Trust. We as APHRC are managing the funds, and the prizes will be awarded eventually by the Wellcome Trust through support from the APHRC. So APHRC will really be carrying the exercise in between that will afford participants an opportunity to put together a winning proposal. And through a proper judicious process of selecting well-reading, well-thought-out proposals together with the Wellcome Trust, those will be funded at the very end. So we'll be playing what you'd call a fund management support to this process for the prize, for the eventual prize winners. We also hope that projects that will be proposed will involve lived experience. Again, I'm just reiterating what was said during the participant orientation, that before we get into the focus of today. And therefore, when we set up this capacity building program, some of these things that we are highlighting will actually be the focus of the modules that were put together, such that when we are reviewing those proposals, we will know that we provide opportunity for people to learn how to incorporate the elements that we'll be looking for, and therefore there won't be a reason why they wouldn't be considered in the final proposals. And as you perhaps know by now, at the very end, there'll be between 5 to 10 awards that will be offered as prizes to multidisciplinary teams that have incorporated lived experiences in them, them and that bring together different skill sets, perhaps within the country or international collaboration within the African region. So I just wanted to recap this, and I hope that answers, especially to some of you who are not there during the orientation program, answer some of the questions that you may have. As Diana said, please let us put the questions that we have in the chat, and we'll be tracking those towards the end. We'll answer what you can answer today, and then provide follow-up answers to questions that we may not have dealt with in the online platform where these courses will be uploaded for you to follow in a self-paced way. Okay, so much about that. Let's get into today's module. I research on mental health at the African Population Health Research Center. My interest is in child and adolescent mental health. I've been working in that area for the last 5 years, and as you can imagine, and you may know that it's an area not just in Africa, but globally that has been neglected for a long time. So it's really an opportune moment for us to be at the center of initiatives that try to make available data for evidence-informed decision-making for policies and programs that can be able to solve this issue that has perennially been neglected, and not just for child and adolescent mental health, but general public mental health. So that's my profile at FHRC, and this really is the right place to start for Mental Health Data Prize, to discuss mental health and why it's important, but more importantly, what will be the focus of the data prize in terms of the areas that will be considered fundable. So our outline for today, we'll be looking at really mental health. And sorry if you're already familiar with this, we cannot assume that everyone else can conceptualize what mental health, can define it properly. So we'll go through that just for to refresh our understanding of that. We'll also look at mental health disorders, but we'll zero in on why anxiety, depression, and psychosis is really important. And I'll borrow some approach from the Welcome Mental Health Strategy that is operational right now, and it's for obvious reasons, because this prize will eventually be awarded by the Welcome. And then we'll be looking at forms and types and designs for research in mental health. And finally, just shortlist some of the tools that we have identified that can be used for population screening for mental health, and some of those that have actually worked in Africa. Some of those tools will perhaps be validated, others will be new, but we'll be listing them, and some of you perhaps already using some of those. So this is our outline for today. And we hope that by the end of this session, you will be able to properly define mental health for those of us perhaps consider uninitiated in this area. We should be able to understand mental health disorders and illnesses, and especially those that we are interested in for the prize, and appreciate the focus of the prize on anxiety, depression, and psychosis, as it were. And finally, appreciate some selected approaches for research in mental health. I see my internet dwindling a bit, so allow me to put off my camera just so that we can assure continuity in this session. Again, I have to find that. Okay, there we go. Yeah, with those objectives in place. So mental health is really defined as a state of well-being in which the individual realizes their own abilities, they can cope with the normal stresses of life, they can work productively and fruitfully, and they are able to make contributions to their community. If an individual is able to do this, if they can willfully do this, they can easily do this, they can, without strain do this, then you'd consider them to be mentally healthy. And therefore, it means that a person who is mentally healthy can therefore enjoy good or healthy relationships with their other people. They can be able to properly put their thoughts together. They can think with clarity. They can think clearly. They can cope with the normal stresses of life, seeing as stress is always in and around us, and we live in a fast-paced environment, and we actually get, to deal with many issues in life, in many facets of life. And a mentally healthy individual should be able to cope with such kind of normal stresses in life without taking a toll on their on their physical health, on their mental health, on their emotional state. They can be productive at school or at work if they're mentally healthy. And finally, they can participate ably and willingly. I think the key word to underline there is ably and willingly in community activities. And you'll see how this really link with the symptoms that are actually used to diagnose some of these conditions, and especially anxiety and depression, the mood disorders, and psychosis to some extent. That if we look at those symptoms closely, they actually align with these facets of life that either define someone as being mentally healthy or characterize an individual to be mentally healthy or not. So we should also know that mental illnesses affect people differently. There are different aspects of an individual's life, an individual's business, and individual interactions that are affected by mental illnesses. We are aware of mood disorders, that conditions that cause abnormalities for the emotional state of an individual. Some actually present as eating disorders, which are characterized by an unhealthy preoccupation with eating. And this could be a lack of a diet, nutritious diet, loss of appetite, or actually excessive appetite. All this could be considered eating disorders. We have substance use disorders, of course, which is impaired control over the use of substances. And this could be alcohol, it could be other drugs, hard drugs available in the environment. We have personality disorders, which are really deviant behavior from societal expectations, behaviors that really go against the grain of societal prescriptions or what is expected by the community, which one would imagine have been cultured over time. So some of the cultural expectations, societal norms are broken by such kind of deviant behavior. Psychotic disorders are exhibited by delusions and hallucinations. And among children, we have behavior that start in childhood that are characterized by erratic conduct or truancy. And this could be an area that requires a little bit further collaboration between research and clinicians, because it may be a thin line between understanding what truant behavior, where truant behavior stops, and where mental health conditions in children really begin. But that will be really the subject of our work in research, perhaps a subject of the proposal that we'll be providing, bringing together multidisciplinary teams to explore such kind of pertinent questions on where really do you say that symptoms are consistent with mental illnesses? And what do you think just erratic or problematic symptoms or behaviors that may not be considered mental illnesses? We can now explore in brief some of the categories of mental illness. And I should say that symptoms to categorize these mental disorders, or symptoms to extract these or diagnose individuals with this, different and are described in the Diagnostic and Statistical Manual for Mental Disorders number 5, which is what is currently in operation. And this manual is mainly used by doctors to diagnose these mental illnesses. So you have mostly up to 6 if you include neurological conditions. But what I've done in this slide is just to show some of what you would consider mental disorders without bringing in some neurological conditions like epilepsy and things like that. So under common mental disorders, and as the word suggests, these are commonly or perverse within the populations, and a number of people may be suffering this without necessarily knowing that they suffer this. So they could be overt, they could be discreet, but they really affect a bigger proportion of the population in which we live in. Actually, Wellcome Trust says millions of people are affected by some of these common disorders. So these are in the form of depressive disorders, also called the sad mood, anxiety disorders, and explains why we're including them in this package of the work for the data prize, and some somatic disorders which are exhibited by bodily symptoms. And some of you may have done research around this area. We have, of course, the severe mental disorders in which psychosis is classified, and schizophrenia, and issues around hearing voices, seeing things, feeling things on the skin, and having unrealistic beliefs, and also some of those debilitating or disabling mood disorders. So the clinically defined depressive disorders can actually be classified under severe mental disorders. We have classification under child and adolescent mental disorders. We have intellectual development disability as an example for that. Attention deficit hyperactivity disorder is another, and oppositional defiant disorder, or ODD, is one of those. Perhaps a number of you could have testimonies around conduct disorder, and some of perhaps people you know in your life who may have been labeled to be problematic and therefore requiring a bit more different upbringing than the rest of the people. And because of something called conduct disorder, perhaps they don't behave like other children, they do not act like other children, they do things out of the ordinary childhood practices and things like that. I will not really belabor the point around substance use disorders, things around alcohol, excessive alcohol consumption, or what we would call problematic alcohol consumption, tobacco use, including the modern tobacco products that are under use in some parts of the world, and other illegal substances. If you're coming from Sierra Leone, for example, I don't know whether we have colleagues from there, you'd be hearing things like kush. If you're in this country, perhaps at the coast, you've seen these substances that are making people, behave like zombies because of consuming some of these substances. And finally, there are conditions which are really closely related to mood disorders, like suicide ideation behaviors. And these are thoughts and plans about killing oneself. All these put together are categories of mental disorders. And like I said, these symptoms are usually defined in Diagnostic and Statistical Manual for Mental Disorders, number 5, which is currently in operation. And the manual is usually used by doctors to help diagnose these mental illnesses. I should put a disclaimer that in this module for today, we are not trying to, we are not sharing on diagnosing mental illnesses, because that's not what we are experts in. We are not looking at the clinical criteria of diagnosing these mental illnesses. We've been focusing more on issues around population level screening and what the definitions of these conditions, especially anxiety, depression, and psychosis, and how this can be screened at the population level. For clinical diagnosis, doctors are well placed, clinicians are well placed, and they have their own psychiatric assessment criteria beyond the symptoms to be able to diagnose individuals. And that's why even in research that we do, we have the gold standard being psychiatric assessments for research done at the community level using the so-called population level screening tools. So they remain symptomatic, they are not diagnostic tools, and we'll be coming to that towards the very end. But for a person to be fully diagnosed, they then would need to go through a psychiatric assessment, in addition to a screening tool that perhaps would bring some probability that an individual would be suffering from mental illnesses. So application of some of these tools in research are very different from clinical assessments for some of these conditions, and they are two different things. So I just wanted to clarify that at this stage. There are a number of things, and there are different frameworks to look at different factors for mental health. A number of frameworks really exist, and you could find really different classifications. One that I'm aware of recently that we have applied in some of our work is the relational well-being for drivers of mental health, especially youth mental health. But by and large, or broadly, you have 3 main classifications of factors or drivers for mental health, things that cause mental health in people. The pathways may not necessarily be clear, and this is really subject of the work that we could be hoping to see from the applicants who are part of this group here today. So we have biological factors, as you can see listed there, and again, these could be things that trigger biological processes, and they are not themselves biological factors. So alcohol could trigger biological processes that really either exacerbate or cause through some mechanism, mental health conditions. And this really has been done through causal linkage or association linkages in epidemiological studies. So you have what's listed there as biological factors. You also have what can be listed as physiological factors, issues around body image, and you can see how that links with self-stigma and self-appreciation. Gambling is a new area in most African countries. Certainly in Kenya, we are seeing a lot of effects linked to sports gambling, problematic gambling, and use of gadgets for perhaps online gaming as well, having a link with mental health, perhaps not mental health disorders, but at least mental health problems, and especially within the younger population. And of course, issues around trauma can be classified under physiological factors. The other category of factors affecting mental health can actually be classified as social factors. Social factors, the environment in which people live, the community in which they live, and how they are treated or how they treat other people, or how they consider themselves either to be lucky or not lucky within the environment in which they live. And that has got everything to do with their socioeconomic, status, the issues around friendships and relationships, issues around employment and occupation. You see how that links back again to socioeconomic status. So you could consider this part of the social determinants of mental health in this case, in the bigger definition of social determinants of health, as it were. Things around work-life balance, and this has been demonstrated in the realization among institutions that if staff are helped to practice work-life balance, combining or learning to balance quality and quantity of work, that they actually report better, health, which is really an exhibition of better mental health, because as we know, there is no health without mental health. So we have social factors, we have physiological factors and biological factors. And I must again reiterate that there are different frameworks that classifies these factors depending on how you want, from which angle you want to look at that. If you're looking at relational well-being structure, you could be looking at individual level factors, which could cut across all these conditions, all these classifications. You could be looking at social factors. You could be looking at environmental factors. It just depends on how you want to classify. By the end of the day, you'll still find all these individual factors, and these are not even half of what you could think for, will still be captured within whatever classification that you want. Diana, you need to remind me if you think I'm moving quite fast. Is there a comment perhaps that thinks that I'm moving fast or something like that?
No, we're okay.
Thank you, Diana. So it would then best to understand who then is more likely to suffer mental health. And the easiest answer there really is that everyone, really, as long as you're alive, living and kicking, you really are at risk of developing a mental disorder or actually suffering mental illness. There would be aspects of life or factors within the environments that we live in that exacerbate or actually increase the risk of people developing mental disorders, and therefore vulnerabilities to develop mental illnesses or to suffer mental illnesses. Certainly people exposed to adverse circumstances, as we've come to know epidemiologically, people exposed to negative childhood experiences, and these are many, including perhaps violation at a younger age, suffering war, civil war, suffering perhaps violence and trauma at the very early in life. Could actually exacerbate or increase the risk of someone suffering mental health in childhood or even later on in life. Things like poverty in the lens of socioeconomic determinants of mental health are really big predictors of mental disorders, and actually put people at risk of developing mental illnesses. Things like, again, I've said violence, people who grow up and live in communities and societies rife in violence, civil war and things like that. There are things linked to generational trauma, linked to war, generational trauma-linked civil strife that have been diagnosed in people suffering things like post-traumatic stress disorders, depression, anxiety, and such like conditions. And of course, things like inequality have a way of leading back to poverty, leading back to discrimination, and leading back to other social ills that again track back to mental disorders and mental illnesses. So you can see that the environment we live can either be protective of mental illnesses or mental disorders, or they can actually be exacerbate mental illness, or can actually enhance the risk of individual developing that. And in the table, I hope you can see this, we have on the first, on the red column, you see some of the adverse factors that are classified as individual, social, environmental, again, based on the relational well-being framework that I mentioned. Things like low self-esteem and cognitive emotional immaturity that can predispose people to mental disorders. Under environment, poor access to basic services, including education, health, and you see how that tracks back to socioeconomic determinants for mental health. Underprotective, as you can imagine, growing up in a good home, being educated, having the basic needs or having access to the basic needs, supportive family, having a job, socioeconomic determinants that improve the quality of life can actually be classified here. At individual level, the ability cognitively to solve problems really improves the performance of people mentally, and as opposed to when they are cognitively weak on the other side. So these materials will be there, and I'm sure you can, within your own environments, really extract some of these drivers, these factors, and classify them in the two columns, and further subdivide whether they're individual or social, that means communal, or within the environment in which people live, and as it were. So this material has been taken from the World Health Organization paper on risks to mental health, and this will be available for you to have a look, perhaps review better, which will be attached to this presentation on our learning platform. So please have a look on the source paper and engage with this much better. Now, there are different manifestations, as you can imagine, different constituencies, different populational groups, population cohorts really do not suffer mental illness proportionally. There's disproportionate burden of mental illnesses in certain age groups, if you use age group as one way of classifying that. Of course, there are different demographic ways of classifying burdens or groups of people. But just looking at age, for example, you can see that some mental illnesses are often prevalent in early life. And one of the most tricky age groups is usually the 20 to 24, as you can see. There's a reason why you're starting at 15, because children below 15 are really not exposed or cognitively aware of some of the challenges they go through to become triggers for poor mental health. But if you look at that age group from around 15, you can see, especially in yellow, things like substance use are really peaked within that age, rising from 15 up in the age 20 to 24. And perhaps when people start maturing and getting big other responsibilities, that may decrease. But we should also know that people exposed to these behaviors earlier rarely would recover and therefore would continue in that trajectory. But population level statistics will show that within these age groups, such age groups will suffer highly when it comes to substance use, and when they grow older, the population grows older, such a thing would be decreasing, for example, for substance use. You can take an example in green depression, and you can actually see that depression actually increases when people even get older. So it, in a way, stabilizes across the age groups. It's still high anyway, up to 5% of the population, up to 6% of the population will be suffering that. But when people get older and become a bit lonely, and perhaps are in communities where homes for the aged are, find a number of these older people who have very little interaction interaction with the outside world become more and more depressed. So this is just one of those studies from the Global Health Data Exchange, the global burden results based on the latest production using data from across the world that really shows that in old age, things like depression increase. And it's no wonder that things like suicides have actually been determined to be higher in the younger population, 15 to 24 age group, and also among older people. So old age suicides, sometimes actually properly hidden, are actually high as compared to the population in between, or the age groups in between. Again, this can be found from the source cited there, and you're welcome to go to the Global Burden Disease Analysis of global data to review these trends and which change depending on how you want to review them. So why then are we only focused on these three conditions when we have shown that there are a number of mental health disorders and different population groups suffer different mental illnesses? Why then are we really focused on anxiety, depression, and psychosis? And really it's because of three things from a practical point of view, that these are conditions which are very perverse. They affect millions of people. Sometimes it's really not obvious that people are suffering these conditions. We also know that anxiety and depression, from studies really, from epidemiological studies and from clinical diagnosis and from health facility data, that anxiety and depression are two conditions that usually co-occur. And finally, we know that anxiety and depression are comorbid conditions in people suffering psychosis. So if we needed any reason why we would focus, if we only had enough time to focus on three conditions, if we were to rank which ones we would go for, then that would take us back to anxiety, depression, and psychosis. But there's also another reason. As I said again, this Mental Health Data Prize is actually funded by the Wellcome Trust. The Wellcome Trust have a new strategy on mental health, and I would welcome you to visit the welcome.org website to have a chance to review this if you hope to package your proposal well for this prize, but also just to position your research going forward. The strategy wants to create transformative change by finding better ways to intervene early so that people suffering anxiety, depression, and psychosis can thrive. You'll find that on their website. But I want to bring us to these three things, what your projects should contribute to. Not necessarily this project, but going forward, if you're interested in carrying out research in mental health at the population level, your project or the research you do should allow us to better understand how the brain, body, and environment, that interplay of these three key, what I call the components of life, how they interact, and how then they predict, these conditions. But to what end? So that we can be able to identify key points, to early and effectively intervene on these conditions. We should also studies or projects or research proposed should help us to better understand ways of identifying and grouping individuals who suffer from these conditions, because one of the things that has really been a challenge, and this links back to many other things, including cultural issues, traditional issues on how we conceptualize and define mental illnesses or mental disorders. So having said that, we should be able to learn from projects that are designed in this day and age on how we can be able to rightfully measure this and therefore properly group people, including identifying other factors, whether at the individual level, at the community level, at the social level, as well as in the environment that can predispose people to suffering mental illness and disorders. So it goes beyond studying the individual. It extends to studying the community in which they come in. It extends to studying the environment in which they live in. It extends to knowing the social environment around them to be able to properly classify and therefore intervene better. And finally, we need to find new ways of intervening, because if we keep doing things the same way and hope to see different results, I think we're lying to ourselves. And I think that's not my word. We know this has been said. We relate with this saying, and it's about time that we change the way we do things. Perhaps we will find better results. And in this case, to bring to the fore issues around mental health and to find solutions for these pervasive conditions that are disabling a number of very many people, millions of people, especially in this part of the world. At the center of this, at the core of this really is research. As a researcher, we are preoccupied with finding solutions. We are preoccupied with finding the missing link between the cause and the effect, between the driver and the outcome of any health condition that we could be researching in. In mental health, we are looking at understanding the issue better, and therefore, as we have seen in the previous slide, intervening at the right time, targeting the right people in terms of beneficiary for interventions, and designing programs that are not just effective, but should also be culturally sensitive, that takes into consideration the environments in which they are being implemented, and the policy environment as well in regarding other supportive services or products that could be required to improve the mental health of people. So research is mainly, especially in mental health, and it's not very different from other areas of research. We can generally classify research approaches in mental health in three classes, and this really is elements of epidemiology. I would invite you to look, to read about this if this sounds new to you, on the different ways of designing projects depending on the research question that we're interested in. But case studies really will utilize a lot of socio-demographic or bibliographic information for individuals. They are a very good way of generating hypotheses when something is not clear, when you do not know what causes what, when you really want to understand the genesis of something and how it progresses to becoming something bigger, or the pathways through which something happens, then it's important that you perhaps start by designing a case study, working with few numbers, perhaps even one case in the condition that you're interested in, and diving deeper to understand very well what the issue is all about and how it progresses from A to Z. It's useful for rare disorders, as you can imagine, because even if you want to do a national level survey, it could be a waste of money. It may not be easy to create participants, but you could find one case that you can explore deeper and further. The only weakness about case studies, as you can imagine, for epidemiological studies, is that you cannot attribute causal inference using findings from case studies. So you cannot rule out alternative hypotheses because you have not spoken to as many people. And if you're going to speak to 1,000 case studies, you better convert that into a different study design. So as you can imagine, it becomes very different to attribute causal inference to case studies. Correlational, as the word suggests, the term suggests, is really looking at the direction of relationship between X and Y, or two factors, or two variables, or two things that we are measuring in individuals. For example, does age correlate with depression? We have seen from the slide on the trends in the age groups that depression is higher in younger people, is stabilized within the middle-aged population, but it increases towards the end. You can answer that question using correlational studies. The only weakness, again, and there could be others, that you cannot determine which one comes first. So which one is the cause, which one is the effect, because these are mostly cross-sectional studies and they do not establish the temporal relationship between one factor compared to the other. I'm sure for the epidemiologists in the room, you're feeling like I'm preaching to the converted, but I'm sure for some people this is perhaps useful to understand that in these three forms of studies, we then see that the experiment approaches is perhaps the most important, the most useful research method, because you can determine causal relationship between one factor to the other. And usually these are either designed as randomized clinical trials. They consider They are perhaps longer, they are implemented over a longer period, and they can measure which one came first between one variable compared to the other. In other words, the cause and effect. So there are three features of a disorder, really, that we may be preoccupied with, that will define how we want to design our study. So it's either prevalence or incidence of the problem, or the risk factors around that problem. And if you want to know how to intervene for a risk factor for a problem, say depression, then you have to design a study in a way that you can effectively do that. And really, the import of this is that this really could be some of those proposals, some of those study designs that will be included within the proposals at the very end. The multidisciplinary proposals could include all this together, or one of the most strongest study designs. I'm not saying that these can be done separately. I mean, within any experimental project, you could actually have case studies, perhaps. Within any cross-sectional study, you could have case studies embedded in them. So the concept of mixed methods in research is really stronger, and perhaps a better approach to doing things than looking at these things in silos or independently, as it were. I will zero in on experimental studies, like I've said, because I think this is really where we should be going, or how we should be thinking in terms of research in mental health, and actually research in any health outcome that we could be interested in. And an experiment, just like the word says, a study in which a treatment or a procedure or a program is intentionally introduced so that you can look at the outcome and say that the outcome is as a result of what we introduced in this. And by introducing, it just means that you could have a new program, a new treatment, or a new way of doing things, and introduce it in the lives of people in a cohort of people, in younger people, and then over time observe what happens and measure the outcomes and attribute the outcomes on the experiment that introduced. And there are 4 elements that are key in any experimental study. Manipulation is one of those, and that's really the introduction of a new treatment, new program. There's a use of controls in RCTs. These are called counterfactuals. There's the issue of random assignments, so not targeting people because they have the attribute of interest, but randomly assigning people in any treatment program. And in terms of evaluating the performance of that program, you can randomly select then beneficiaries of such program to be able to measure the outcome in them. So these really are the main elements of any experimental studies. Unfortunately, delving deeper into this is outside the scope of this module for today, but I'm sure the modules that will be coming, including study designs that will be handled by my colleagues, will delve deeper into this. So we're just introducing this and placing them at the center of mental health research. So when something is manipulated and controlled, because manipulation and control are the 2 most important elements of experimental studies, then the outcome happens, and it makes us more confident that the manipulation caused the outcome. So that's how you look at it, that when you manipulate something and then you have controlled that environment by having a counterfactual, then you can go back and say, really, what I am seeing as the outcome is as a result of the manipulation and not some chance or some outside factor that may not have been measured. Of course, for epidemiologists, we know about, at least individuals involved in research know about collecting data on confounders or any factor that could mediate, modulate, or affect the outcome in any experiment that you're doing. So really, I just wanted to highlight the experimental studies because of the strength they bring, especially in assessing cause and effect, and attributing or inferring causality, as well as finding the temporal association between one factor to the other. And this perhaps would make any proposal to study not just mental health outcomes stronger compared to another that would be submitted to the same scheme. Again, if you know this, I must apologize for preaching to the converted. But as my ED would always say, sometimes you have to say things many times over and over again. And sometimes they actually sound interesting every time we say them over and over again. Like I said, the case studies, the correlational studies that we looked at and the experimental studies can be done either at one point in time, or they can actually be done over and over in a repeated way, measuring this at different time points on the same individuals. I will really not belabor this point, but I just wanted to show how there are differences and strengths between longitudinal studies. But I want us to bring, especially with respect to mental health, the approach on what we call high-risk longitudinal methods in mental health research. And in this case, it starts with screening individuals who could be at higher risk, probable cases for mental health, and measuring certain outcomes or certain attributes over time to get longitudinal structure to the data obtained from this individual. So although longitudinal is a bigger name that talks about studies on individuals or participants over time and can actually help us isolate cause to effect, for studies on outcomes like mental health, perhaps an approach like high-risk longitudinal method, where individuals are initially screened, although we know such conditions are transient and can happen to different individuals at different times. But for whichever cohort you could be interested in, could be screened at baseline and followed over time, especially among the so-called high-risk participants, and being able to identify the outcome later. Of course, ethically, if you would just be doing that as an observation study, there are other conversations around that, but that is outside the remit or outside the scope of today's module. There are all those considerations when designing these studies. Ladies and gentlemen, I'm almost in my last slide, but I just wanted to share based on the outcome of the scoping work that we're doing. So we are not just looking at
Hey, Frederick, we've lost you. Hello, Frederick.
Yeah, I think he's having some network problem.
Okay. Okay, let's give him a few minutes.
Joel. So thank you. This is where we were, right? Joel.
Yes, sure.
Okay. Yeah.
Okay.
Now I was just sharing with participants that we in our scoping work, we're not just interested in data sets, but it's also important to link data sets to the tools used. Of course, in our settings, it's imperative that we understand the burden of mental health problems in the population. It's not always easy to get the screening and management done at health facilities, and therefore the availability of easy to use validated tools that can be employed at the population level is really important. And it helps us really understand not least the burden, but can be a tool that is used for referral for further confirmation and initiation for treatment for those people confirmed to have these conditions. So we have had quite a number of tools, really. Some are widely used and in several settings, several populations, and others are newer, informed by lessons learned or, by new validation studies that have caused their improvements or revisions. And others are being imported from different population groups and being tried in our population settings and things like that. So what we're listing here really are a mix of what has been validated, translated into local languages. And I'm aware that in most African populations, you'll see a number of studies, especially cross-sectional, PhD, masters, and some of subpopulation level studies have employed some of these tools. The General Anxiety Disorder GAD-7 tool, the Patient Health Questionnaire, this I think extends from PHQ-2, PHQ-7, and PHQ-9. And in most settings, this is actually just used to screen before further assessments are done on the individuals. So it could be that you're doing a population level screening and identifying individuals whose symptoms are consistent with conditions like depression, and then are taken through better diagnostic tools, including psychiatric assessment or clinician assessments. We have other tools like the Strengths and Difficulty Questionnaire, except for the length. But this is one very big tool that has several components and screens for many other conditions. So it's not just one. Unlike PHQ that looks mostly at mood disorders, in this case depression, you have SDQ that has multiple conditions that are reviewed. And others are there, tried, newer, novel, that we may not have listed here, but I'm sure in your research, you perhaps are testing or validating some of these tools, and perhaps you'll be ready to do that. But for purposes of this prize, or for the purposes of research on anxiety, depression, and psychosis, it's important to demonstrate how tools used in the data that you're currently holding have been validated in the setting in which you are, or if you are validating for the first time, what is the performance, the psychometric properties of some of these tools, and how then are your recommendations to improve, or whether you're digitizing them and making improvements in the way digital formats, electronic formats of these tools can be used not just to screen, but to refer or linked to national, databases and things like that. So there's so much that what we have in terms of offering, in terms of tools used at the population level for screening of mental health, can actually offer in the business, or at least in the assignments, that the program that we're embarking on. So I just wanted to share some of this as we finish this module. These materials, we will keep curating the content that you're interested in, the areas that you want further information in, and adding on to this. But for now, as an introductory module, we thought that these would be the areas where we would introduce you to, and then keep adding materials as we review the areas of interest that is coming from you, even as you continue interacting with the other modules. So Joel and Diana, I will want to stop there again, and thank the participants for tuning in, and hope to continue interacting with them. Please feel free to send us your questions. Also send us in inputs from the orientation. You saw the part of the portal where you can create communities and discuss issues. There are people in this 500 now, and 15 people who are experts, who are already researching in this area and could have something to offer. And they would also require something to be offered in the work that they do. And such communities, we can call them communities of practice in this program now. The interactions will really, really enrich not just what we've discussed today, but what we will keep discussing in the 5-month capacity building program that we're embarking on. Again, I should say that if there will be need to revisit this and update some of these sections that we have based on the feedback that we receive from you, we would be happy to do that. And if we find resource people within the partnership that we have started building today, who have additional insights and newer ways of doing things, perhaps are testing newer tools. We will be welcoming such kind of input into this community and making it prominent so that we can advance the matchmaking exercise, the teaming that will result into winnable proposals to help us find better ways of doing things, diagnosing, treating, and managing anxiety, depression, and psychosis. Over to you, Diana and Joel. I think it's a quick Q&A session now.
Yes, Frederick, thank you so much for that. You have a few questions. Somebody is asking, I'll just take a few from Q&A. Somebody is asking, what is clear delineation between psychosis and schizophrenia? I don't know whether you'll take it one by one or should I note them down? Then
again, like I said, and I really would want us not to go into areas that will sound more clinical and into diagnosis of mental illnesses, because really that's not the focus of this work. But what we know is that psychosis and psychotic disorders exist on a continuum. So there are mild forms, but schizophrenia within the category that we saw earlier in the psychotic category of conditions, schizophrenia is people who hear things, have this heightened worry that something's going to happen to them. They hear voices and they behave in such a way, and you could feel some kind of that they are afraid that something would happen to them. Psychosis, on the other hand, is a brain illness, a mental illnesses that is manifested in people. You know, those people that perhaps look dirty, they undress, they are not in control of their faculties, really. So you could have, for lack of a better word, decent schizophrenia, maybe that's not the word, but it's not necessarily linked to conditions that look like people who have lost it or people who have lost control of their, faculties. So I would say that's the thing. It's more about fearing, excessive fear, hearing voices that are not there, distrust, paranoia, excessive paranoia, I guess that's the word. And as unlike mental illness that has really affected people who have lost control of their life and are not really they look different from the rest of the population. Go ahead, Anna.
okay, another person is asking also what sort of diet causes mental health illness. It was presented that certain diet causes mental illness.
And like I said, those are what we call biological factors. The pathways is never straightforward, really. So diets, just like alcohol or these are things, trigger pathways within human beings that lead to certain mental health conditions. It may not be one clear one, or else then we would easily remove them on the shelves and say, don't take this because it will lead that. But you could track different pathways. And really, I would want to challenge the participants to look at that. And maybe that will be an area for our discussion in the community that we're putting together. So the pathway is really just like nothing really has been shown to cause mental health or mental illnesses. There's no clear way you could say alcohol causes mental illness, but there's an association between alcohol consumption and mental illnesses through an intricate pathway, biological, biochemical pathway that predisposes or exacerbates the risk of developing mental illnesses, as it were. So I know that's not a sufficient answer, but it's really a good place to start our conversations in the community groups that will be forming on our platform.
Okay. Another one is asking, why does the mental health seem to decrease as age increases? So we want more elaboration on that.
I should clarify that mental health does not, because what is mental health? Again, I think it was important for us to define that. So mental illnesses are the conditions we suffer that affect our mental health. Mental health is a state where people can contribute productively to their society, right? And when they fail to do that, then they become mentally ill. So mental ill health is these other things that we have looked at. Depression, anxiety, psychosis, and all those are now mental illnesses. I should say that from what we saw, really, there are different mental illnesses. Maybe I should go back to that slide just quickly to demonstrate my point. The truth is not that these conditions decrease, but most of the mental illnesses that we have listed here would affect mostly the younger population. Like I said, the 15 to 24 age group has been highlighted even by the World Health Organization to disproportionately suffer the burden of mental illnesses. Again, as you can see, these are very few conditions. And if we increase this number and increase the lines here, we would see some of those that would be higher. Things like dementia or Alzheimer's disease related dementias, if you classify them as mental illnesses, would be higher in the old age compared to the younger people, right? Of course, we know there's early onset of things like dementia, but I don't think they would equate to what we're seeing in old age. So the import of this graph was not to show that mental illness decrease, because this is not a trend showing an individual or from young to old age. It's the measurement of the burden in these different age groups. So what you're seeing there is the burden of these conditions within these age groups, and it could change depending on the conditions that we decided to show here. I hope that answers the question.
Okay, thank you. Thank you for that. Another one, where can we find the African data set in mental health?
It's interesting that you find that. So really, and that's the reason why we are doing the scoping review that we need. And I'll surprise you, within this community here, the 500 people that are here today, some of them have these data sets, and I'm sure have the willingness and the desire to share these data sets to help us understand what's happening in the region. So in terms of raw data sets, they could actually be sitting with the 500 people who have tuned in today. In terms of where else you could find this, the scoping reviews that we have done have shown that there are different studies done in the region, and we have looked at them. Now, data sets availability does not mean data set accessibility, because like any product of research, data sets are held by researchers who have produced them, and who may require people to request for them before they can share them, or who may require some lead time to look through the data before they can share them. These are common practices in research, and many studies or many projects would make their data available on request. If you look at papers published, there'll always be that statement on data sharing. In APHRC, for example, we have something called the APHRC microdata portal. I'm not talking about mental health data, but we have some data that we have done research on for the last 20 years that have been described there. And the practice that I'm aware of, if someone went to our APHRC microdata portal, looked at the data set that we have there, and requested to use them in analyzing something that has not been analyzed, 9.5 out of 10, the request is always granted. So there are many ways to access data, but I think it's safe to say that among the 500 people who have tuned in today, there are so many data sets on mental health in the African population.
Okay, thank you. I think I'll take two questions from the people who have raised their hands. I will give a chance to Damiler, I hope I pronounce it well, to ask the question. Okay, I think he's okay, I'll give a chance to Fufu Olana. Fufa, sorry. Fufa? Are you there? You're muted. Okay, it seems I cannot get to the person. Okay, I'll give a chance to Mirembe. Mirembe, you can just unmute yourself and speak.
Hello, everyone. I didn't know that my hand
Hi.
was raised. Sorry, I didn't.
Oh, it's fine, it's fine. Okay, fine. Let me give the chance to another person. Usman. Usman, are you there?
Yes, I'm here.
Okay, you can ask your question. Your hand is up.
Oh, sorry. Then it was a mistake. I didn't raise my hand. I'm okay.
Okay, it's fine. Okay, let me try Jacob. If you raise your hands, for us, we take it as you want an opportunity to ask your question. So kindly just raise your hands if you want to ask a question. So I'll give this chance to Jacob Apibila. Jacob, are you there?
Yeah, hello, can you hear me?
Yes, we can hear you.
Okay, so Dr. Fred was talking about scope review. So I want him to recap. Is it that we are going to do scope reviews or it has already been done? Thank you.
Yeah, Osman. So, no, I said that is an assignment that we have embarked on. So, well, you could do it, but not just for the purpose of the prize. I don't think that fits into that. And then I think information around the guidelines of the prize, if they have not been released, I think they'll be released later on what qualifies. But by and large, Osman had mentioned that our focus really, and this was the focus of our orientation meeting the other day, was that we will be hoping that groups, the multidisciplinary team that comes together, does not propose to do new research, does not propose to do systematic reviews, and does not propose to do scoping reviews. The idea would be to look in and around your projects and programs and utilize the data you have collected, because there's so much data around us, and there are many ways of using data we already have through a multidisciplinary team of, say, data scientists, social scientists, developers of applications, people with lived experiences, and community mobilizers. I'm just raising some of the people. If you are to bring these people together with data or a program around a project that is already ongoing, that offers to provide a solution for the three conditions. It could be an application, it could be a new way of doing things, it could be a new way of engaging people with lived experiences. So the products that can come out of these are endless. It's just not primary research on the prevalence of anxiety, depression, and psychosis. We will not be looking at such kind of proposals. I understand that we may not address all those questions during this because there are many sessions designed to address those questions, but it was meant to be addressed during the orientation, and we will make that information now available on our website if it's not there. It's a whole document that answers all your questions, including frequently asked questions on what will qualify as a mental health data prize project and what areas would we be interested in, over and above the fact that it brings together a multidisciplinary team, involves people with lived experiences, involves policymakers and other key stakeholders, and it's really, really, truly multidisciplinary in nature and offers solutions on the three priority conditions of anxiety, depression, and psychosis. Osman, I hope that points you to the right direction, but we will share the guidelines if they have already not been shared. Joel, do you know whether we have already uploaded the guidelines? Joel?
Not yet. We have not yet uploaded the document.
Okay. Yeah. So we
Yes.
will be going through this capacity building, but we will release these guidelines because the application for the award itself will come after 5 months. So we still have time to release guidelines on projects, but just know that whatever ideas we'll be thinking about should not include primary data collection, and it should include people from different disciplines. We cannot reiterate that enough.
Okay, thank you, Fred. I'll give an opportunity to Priska to ask a question. Priska, are you there?
Yes, I'm here. Hello, everyone. My name is Priska from Nairobi, Kenya. I have a question on chronic illnesses. There are cases where patients who undergo chronic illnesses such as cancer or even cardiovascular diseases suffer mental illness. In which category do we categorize these kinds of people or this kind of mental disease? Thank you.
Yeah. Priska, very interesting question. Yeah, so you could look at suffering chronic illnesses as a factor predisposing people to suffer mental illnesses, which could be mostly issues around depression and perhaps issues around suicide ideation and self-harm and things like that. So the fact that they are suffering chronic illness then becomes, you could call it as, I don't know whether you call it an individual factor, depending on how you want to classify it, but certainly a driver or a factor for the mental illness in this case, which would be depression. So I wouldn't classify the chronic illness itself as a mental illness, really. But while we are there are things like substance use, which are classified both as a driver for poor mental illness. There's a clear link between substance use and psychosis, but in itself, substance use is actually a mental illness. So there are these different classifications, especially when it comes to substance use, both as a cause and a consequence when it comes to mental health, or both as a factor and an outcome when it comes to mental health. But as far as I know, it's mostly really around substance use, which is the most classic example when it comes to that dual classification.
Okay, thank you so much, Fred. Priska, I hope your question has been answered. So
Yes,
would
yes,
like
thank
to,
you.
oh, you okay? Okay. Would like to end at this. All the questions that is on the Q&A, we'll try to answer them on the frequently asked questions on our platform. So for now, we would like to end at this. We hope your training objectives have been met. So we'll communicate the next date for the next session. So we thank you so much for joining this training. Frederick, do you have any last remarks?
No, thank you so much, Diana. Thank you, Joel, and thank you, participants, for coming up. I just want to reiterate the benefit of linking all these different modules, because we have selected them based on a needs assessment that was sent out to potential participants, and these are curated to answer the needs or to address the needs of the participants who have signed up for this program. So it will really be great if you can participate in as many as possible, because some of the questions that have not been answered today will be taken through to the next module, and we'll try to string everything together to the very end. So we'll be looking at what's emerging and incorporating that in the next module and building and improving this. And again, I've said we'll be taking input from the community of practice that will be forming, from the insights from the people who are also here who are experts, and maybe you may have material that you want to share. You may want to correct some of the misconceptions that perhaps we perpetuate in these sessions, as is always sometimes the case of misunderstanding. And then by the end of the day, we have an enlightened community with common understanding, but at the center of it really that we are better equipped to address anxiety, depression, and psychosis. And for those that will be applying at the very end for the prize, that they can put together a solid proposal that takes into consideration all the guidance you've provided, then the proposals can be considered winnable. We will be awarding 5 to 10 at the very end, courtesy of welcome. And we really hope that some of those who are here today will be there with us at the very end. So thank you very much. That's my last word, then.
Okay, thank you so much. Thank you everyone for joining this training once more. Have a great day, evening. Goodbye. Thank you.
Thank you.
Bye bye, everyone.
Bye.